morning, everybody. Welcome to this open co-design workshop with title Next Generation Tools to Manage Amyotrophic Lateral Sclerosis and Multiple Sclerosis. Let me introduce myself. I'm Manuel Ottaviano from Technical University of Madrid, Universidad Politécnica de Madrid in Spain. I'm a senior research manager devoted to the design of solutions for patient and health professionals in the field of digital health. I'm involved in this project, BRAINTEASER, and I'm also responsible for the design activities of the ICT services for patient and health professionals with those type of disease. And the main goal of this workshop is to start open discussion with stakeholders and also with the public audience about these next generation tools for ALS and MS patients and health professionals and also caregivers. In this, today we have a great opportunity to have in this session invited speakers and also people working in this project. And yes, with this we will start the discussion, and we will, thanks to your feedback and also recommendation, we will be able to advance on the definition of these next generation tools. The workshop will be like a two and a half hour workshop, in which first you will have an overall presentation of the BRAINTEASER project, and we will have presentation from the coordinator and from the technical manager of this project. And then we will start, thanks to also the participation of the panelists, we will start a co-design session that will be also interactive, in which we are going to show you some screens, and also the audience and or even the panelists will be able to participate in this open discussion with the goal to discuss with you the proposed approach and try to refine. I will also have some support from other partners of the project, like Arianna Dagnati, that will help me during the workshop to coordinate all these activities of design and to also discuss the part of the environmental services that we are going to present you later. So let's start with this very intense agenda. Let's start with the first presentation from Maria Fernanda Cabrera from Universidad Politécnica de Madrid. Now I give the floor to her, and I invite her to present herself and to start the presentation.
Thank you, Manuel. Thank you, Manuel, for the presentation. My name is Maria Fernanda Cabrera, and I am professor of biomedical engineering at Universidad Politécnica de Madrid, the same group that Manuel introduced before. And as he said, I am the coordinator of BRAINTEASER. I also want to thank you for attending this session, because it's extremely important for us to having you here as representative of the key stakeholders that in the near future will pave the way for the acceptance of the innovation that here we are proposing and discussing. So in this presentation, I will give an introduction to the concept of the project. First of all, BRAINTEASER stands for Bringing Artificial Intelligence Home for a Better Care of Amyotrophic Lateral Sclerosis and Multiple Sclerosis. This is a research and innovation project designed and currently being developed and deployed by 11 partners that represent the multidisciplinary and complementary skills coming from universities, research centers, industry, reference hospitals in the field, short and medium enterprises, and non-profit organizations that are from Portugal, Spain, Italy, Serbia, the Netherlands, and Ireland. So in total covering 6 European countries. This initiative started in January this year and will last until December 2024, so in total 4 years duration, and has a total budget of approximately 5.9 million euros. This project was approved under the Horizon 2020 framework program in the call dealing with personalized early risk prediction, prevention, and intervention based on artificial intelligence and big data technologies. So the main idea behind is to contribute to the definition of the treatments of the future, where we will offer intelligent systems for making personalized decisions, optimizing disease management, and also very important, empowering patients. Through the use of different digital technologies and new emerging technologies like artificial intelligence, wearable and IoT devices, cloud computing, mobile health, and most importantly, the data. With the aim of developing new treatment models that will support clinical decision-making, inform the patient, and also provide personalized treatments for the patients that are suffering multiple sclerosis and amyotrophic lateral sclerosis. As you know, amyotrophic lateral sclerosis is a fatal neurodegenerative disorder that is characterized by the degeneration of the motor neurons. It causes the paralysis of the muscles and usually leads to the death into a period of 2 to 5 years after the onset. There is a high incidence of ALS in Europe of around 2.6 cases for 100,000 people per year. And there are a lot, is more than 30 different genetic conditions that are linked with this disease. And the progression rate and the pattern are very variable that progressively impair the ability of the patient to move, communicate, swallow, or breathe and walk. So it will be really extremely important to predict the progression of this disease to improve the prognostication and also the intervention in the clinical routine of the practice of this of the doctors dealing with this disease. The patient with multiple sclerosis also suffer from the central nervous system and is a cause of permanent disability in many young adults. There are different clinical symptoms, and these are variable, but mainly involve sensory, motor, and visual pathways. So the cause of this disease is characterized in most of the cases by an initial phase where the patient experiments various episodes of impairment, and then is followed by complete remission or partial remission with a certain stability between the different attacks. So if this relapsing phase is left untreated, it can be followed by secondary progression that will progressively impair the user, the patient, and will lead to irreversible disability. These two diseases also create a lot of burden for the caregivers. The case study for BRAINTEASER is based on these two neuromotor diseases that even if they have different disease course, they are characterized by multimorbidity and progressive or alternative impairment involving different neurological functions, motor, cerebellar, sensory, and visual cognition, etc. They are very complex diseases characterized in both their onset and the progression. There are several measures that aim to capture the disease state and progression. However, there is barely a consensus on which one is the best to use. And finally, the current definitions really consider longitudinal patterns and do not capture patient variability and population heterogeneity. With this, clinicians need models and tools able to deepen disease understanding, support a multifactorial view of the disease dynamic, suggest personalized therapeutic decisions, and need to prevent adverse events and prevent fast disease progression. Need to indicate the need of urgent interventions, and also require help or support in the design and analysis of clinical trials. On the other hand, patients also have different needs related to the different periods where they experiment care at home and then alternated to periods in hospital. They have a constant uncertainty regarding the timing of the different disease phases. They face a considerable psychological and economic burden, and they need to, obviously, to plan their future. They require to be assisted in their daily needs, and they want to have suggestions on healthy habits and demand to have some alarm systems that can help them in identifying early risk situations. Taking this into account, this context, and also the existing needs, the scope of this project is to develop personalized, artificial intelligence-based healthcare pathways, to develop both predictive and preventive models for patient stratification and disease progression, and to monitor the disease progression in order to improve diagnosis, treatment, and care of the patients, and to ensure subsequent follow-up of the disease within an outpatient setting. Using a data model that allows a better prognosis based on the integration of clinical data with environmental data, biomedical sensor data, and self-completed questionnaires, and through a technological infrastructure that will be set up to create tools that support clinical decisions by identifying different risk factors that make possible to stratify the patients, characterize the progression of the disease, as well as to define the effects of the treatment, and on the other hand, to empower patients, allowing them to contribute to the decisions made about their care, increasing their confidence in the treatment. Now I leave the floor to my colleague, Barbara Di Camillo, that is the technical coordinator of the project and will give you more insights about how we are implementing this initiative.
Sorry, Manuel, you are muted.
Okay, so thank you, Maria Fernanda, for your presentation. Now is the turn of Barbara Di Camillo. She is the BRAINTEASER Scientific and Technical Manager. I want to just add a little note before her presentation that we received already one question from the public, and we will address all the questions of this part after this presentation, after Barbara's presentation. Okay, so feel free to drop messages in this chat of question and answer, and then we will time to time we will manage all the question and try to answer. Okay, so I leave the floor to Barbara Di Camillo. Barbara.
Good morning to everybody, and thank you for being here. Thank you, Manuel and Maria Fernanda, for the introduction. I'm going to share the screen. And I'm going to talk about the challenges faced by BRAINTEASER project. Well, as Professor Cabrera already introduced, the objective of BRAINTEASER is to pursue better care for amyotrophic lateral sclerosis and multiple sclerosis patients. And this is based on two main objectives. The first, developing predictive AI models for patient stratification and disease progression. And the second is to introduce the use of AI model in real life. So in clinics and also in patients' life, to inform them, to help clinical decision-making, to simulate in silico trials, and to provide personalized medicine suggestions. And in this BRAINTEASER, let's say, put the focus on healthcare professionals and patients and caregivers needs and interaction. There are 7, let's say, pillars of BRAINTEASER vision and consequently 7 related challenges, which are the following. So we want to build a more comprehensive overview of patients' healthcare. We want to use artificial intelligence to support this vision and to promote fast and accurate feedback between patients and clinicians. We want to, therefore, empower patients and caregivers, deliver a cost-effective, inclusive solutions, and adopt an open science approach. In all this, we cannot forget ethical, privacy, organizational, and regulatory aspects that contribute to the regulatory framework for the use of AI in the context of software as medical device. So let's start from the first challenge, the comprehensive view of health. Well, this view is based on a comprehensive use of data. So we cannot forget that we need a rich data set and longitudinal data set. So we need to take into account the dynamic aspects of the disease progression. And we want to include mobile and sensors data collected directly from patients using mobile phones, apps, and simple sensors. We want to use a large collection of clinical retrospective data, and we want to use both retrospective and prospective environmental data, because this allows us to compute the exposure of patients to pollutants, so the exposure in space and in time to different pollutants. Then the comprehensive overview of health somehow include the comprehensive view of the final user needs. So here I'm proposing a slide that Professor Cabrera already shown, but really to highlight the fact that we want to start from the needs, the language, and the context of the final user. And this is strongly part of this comprehensive overview of health. The second point, the use of artificial intelligence to support health. Well, artificial intelligence tries to emulate tasks that are normally performed by human intelligence, such as recognizing patterns, taking decisions, evaluate, and predict. Therefore, we are starting from data and apply artificial intelligence to learn from the data, but also to validate and test our decisions on the data, and to develop models. But then to support health, we need this model to give feedback to the patients through apps and to the clinicians through other software and dashboards that allow clinicians to evaluate the outcome of the AI models. And what are we going to predict and to do with the AI model? We want to stratify patients in order to account for different evolutions of the disease, but also to dissect the relationships among variables, because this gives a more clear view of the disease, a more clear understanding. We want to define subgroups of patients characterized by different diagnostic, prognostic, and maybe different treatment, and to predict the disease progression over time in order to obtain, on one hand, a robust set of predictors of disease progression, and on the other, models that are based on subject-specific characteristics. So, for example, here you can see the evolution, the predicted evolution of the disease in terms of impairment for patients, for groups of patients with different characteristics. Then we want to continuously monitor patients in order to quantify the severity of the disease, the severity of symptoms, and the stage of the disease, coupling routine visits that happens every 3-6 months with continuum monitoring by sensors. And this is really important because this would allow to implement alert mechanisms that allow early detection of patients' complications and prompt intervention, as you can see in the cartoon, and also allow to develop predictive models that can alert about an adverse event with some advance, and also allow reasoning about which are the clinical features that are important to predict and maybe prevent adverse outcomes. In order all of this to be useful, of course, we need to close the loop between patients and clinicians. And so we have clinical reports and sensor data, questionnaires data, and storytelling from patients and caregivers that can give input to the developed models. These models have an output that is given to a dashboard, and the clinicians can evaluate, decide, prescribe, and communicate with the patients. And the patients have a mixed automatic and human-mediated feedback that allow continuous monitoring, information, give suggestions, feedback, prognosis in an overall personalized medicine approach. Of course, all of this will empower patients, caregiver, and clinicians. So we want to foster self-management, including in the app educational content, modules to report and manage the symptoms, and also services to improve treatment adherence. We want to link patients with patients associations, with events and materials that might be available. We want to foster a healthy lifestyle in terms of physical activity whenever possible, healthy dietary habits, sleep, to inform on the exposure of to outdoor pollutants, to provide support to emotional distress. And on the other hand, clinicians will be supported in decision-making and intervention planning, because as was showing in the previous slides, they will be provided with interactive dashboards able to answer both at population and at single patient's level, to queries regarding disease dynamics, variable distribution and interaction, simulation of disease progression, treatment effects, and forecasting. And such tools will integrate real-time updates of patient status at home collected through sensors and apps. You might have noticed already, but all of this is based on quite general and cheap technologies, such as mobile apps and wearable smartwatches, but specific and personalized service according to the specific disease and the stage of the disease. We are also considering to extend the possible interaction mechanisms using low-cost wearable EEG headbands that include tools for assisting patient self-expression in terms of ability to communicate with the app. And also we are monitoring the acceptance and utility of the app using questionnaires and surveys. We want also to maximize the outcomes of the project using an open science approach. So we will be compliant with the European Open Science Cloud services that want to assure open data representation standards together with privacy and security in order to have fully anonymous but reusable data, so data that can be reused by other scientific projects or for scientific purposes. We will give access to the knowledge advances, developed models and publications of the projects. We will also organize the open and annual evaluation challenges in order to ensure comparison of our model with the models developed by other scientists, and this will improve the safety and the accuracy of the AI models that will be finally used within the apps and the dashboards. And we want to adopt also a citizen science and the patient data ownership perspective, involving patients and their associations to support the organization of the open challenges. And finally, we will contribute with the documentation in the definition of a regulatory framework for the adoption of AI tools and methods in real life. All of these must take into account 7 pillars for trustworthy AI use that are listed here. So human agency and oversight. And in this project, we implement a natural human in command approach where clinicians can overrule AI suggestions by default and patients maintain the right to express their point of view. We have to take particular care to technical robustness and safety. This implies not only security, but also accuracy, reliability, and reproducibility of AI results, transparency. All our models will be fully documented, focusing on the explainability of the process and of the decisions. We have to keep in mind, of course, non-discrimination and fairness, and this somehow is included in the design of the project that use retrospective data from hospitals, and therefore by design we are collecting data from the entire patients populations that are included in the hospital's registries. Well-being, we have to ensure that the impact of the use of AI tool is controlled. So we monitor the effects of using our solutions in terms of benefits, but also in terms of risk and contraindication, for example, anxiety for patients. accountability. We will keep track of model performance in time and put in place accessible mechanism to ensure redress of models in case this is needed. And finally, privacy and data governance. All the data in our project will be fully anonymized before implementing the AI model. So only clinicians will be able to reconstruct the identity of patients, of their patients in the hospitals. So something that they already know. And patients always maintain the property of the data, and they have always the right to exit the study or to withdraw their data if they wish. And with this, I have finished this introduction, and now it's time for co-designing, of course, and to be able to address all the challenges of these projects. As I have already mentioned, we need really the collaboration of caregivers, patients, clinicians, and patients association. So I thank you for your attention, and I give back to Manuel
Yes.
the stage.
Thank you, Barbara, for the presentation. I would like to, I see that in the question and answer channel, there are two questions from Roland Pochet, from Belgian Brain Council General Secretary. And my proposal is to try to address now, maybe Maria Fernanda and Barbara can answer to those questions are specifically related to the BRAINTEASER project. And the first one is, can you explain why you have chosen two neurodegenerative disease? Why not Parkinson and or Huntington? Why limited to two disease? I don't know if Barbara or Maria can address.
Okay, I can say something, and then Barbara, if you want to complement. Yeah, we could have chosen Parkinson, we could have chosen Huntington. I mean, the reason why is that we were working already with these two diseases, and we counted with the collaboration with reference medical centers working in this area, that they could really provide, and this is very much related with the next question about how getting the data, because we cannot develop models if we don't have the data. So that's why Barbara mentioned in her presentation about retrospective. It's not only the longitudinal data that we will get during the course of the project, but we also need this retrospective data that thanks to our partnership with these 4 reference medical centers in this field, we count with these pre-existing data sets that will allow us the elaboration of these models that we are proposing. So that's the main reason. I don't know, Barbara, if you want to complement.
Yeah, I agree completely with your answer. And I could mention also that one difficulty is to, of course, obtain a hair of the data, and therefore, as Maria was telling, we started from a already consolidated collaboration. But also, since the project is focusing on the real use of AI in clinics and in patients' life, I think that even in that phase, it's really important to have already a consolidated collaborations with clinicians in order to be able to organize, you know, all the path that brings AI to real life, because this is going to be to have some complexities, of course. It's something new in our experience as a scientific community, but also as a clinical community and as patient community.
Thank you, Barbara and Maria Fernanda. Now there is also another question that is more detailed about the consortium. So you can tell us who will provide you the necessary data to conduct your projects. So
yeah, as I said before, we have 4 clinical centers involved in the project as part of the consortium, and these are a center in Turin, a center in Pavia, a center in Lisbon, and a center in Madrid. So there are 4 partners, some of them dealing only with MS and some of them dealing with ALS. We can provide you more details about the specific name of the partners and the main medical professionals in these centers, if you want.
Okay, thank you, Maria Fernanda. So I hope that all this answer will address the request from Roland Pochet. And in case that there are other questions, please feel free to write a question in this channel of question and answer. And now we move on to the presentation of our panelists that will be involved in these co-design activities. So let me introduce first Evie Reviews, chairwoman of Europulse. Please, Evie, can you switch on your camera and present yourself?
Hi, everyone. I'm Eva Reveres. I'm the chairwoman of Europulse, but I'm also involved in the board of directors of the International Alliance, and I'm working as CEO of the ALS NIA Belgium as a patient representative. So hi, everyone.
Thank you. Now is the turn of Ata Chokhachain from Klimafuchs, expert on environmental health. Please, Ata.
Yeah, thank you for the introduction. I'm Ata. I'm the founding partner of Climate Flux, where we work on the development of tools and methods to predict the microclimate and outdoor comfort and people's exposure to the environmental qualities. And I'm very happy to be part of this workshop to have an exchange on these topics.
Thank you, Ata. Please, you as a panelist, can you leave the camera switch on, because then for the next part of the workshop will be helpful to see you. And now is the turn of Felipe Gonçalves. He's a physiotherapist from the Apela Association.
Good morning, everyone, and thank you for the invitation. I'm Felipe Gonçalves. I work at Apela, that is a Portuguese association through ALS caregivers, patients, and the community. We exist, it's our 25th anniversary, and our main goal is exactly that, is to work through the community and for the community in correlations with the different hospitalized centers and home care providers.
Thank you. Pedro Carrascal, President of the European Multiple Sclerosis Platform.
Hi, everybody. Good morning. I'm Pedro Carrascal. I'm also the CEO of the Spanish MS Society and the actual president of the MS European MS Platform. Happy you join the discussion. We're interested.
Thank you. Then we have also Panos Sakanikas. He's a researcher for Institute for Communication of the National Technical University of Athens.
Thank you very much, Manuel. Thank you very much for the invitation to be part of this workshop. I'm with ICCS, the Institute of Communication and Computer System Institute. And we are the coordinator partner of a very close related to BRAINTEASER project, which is called Alameda. We also have those concepts in our minds, and it's very useful for us and to exchange some experience and ideas.
Okay, thank you. Thank you so much. So now in this last part of this workshop, we are going to start these co-design activities. I will have also the support of another member of the consortium of BRAINTEASER. She's Arianna Dagliati. Arianna, can you present yourself?
Yeah, thank you very much, Manuel. So I'm Arianna Dagliati. I'm an assistant professor at the School of Engineering at the University of Pavia, where I work mainly on exposure models based on the integration of data coming from heterogeneous sources. So indeed, within BRAINTEASER with my group, we are focusing on retrieving and integrating environmental data to enhance the MS and ALS progression models.
Thank you. So for this part of the workshop, I prepared a whiteboard, an interactive whiteboard that now we are going to send through the chat. You will be able to access to this whiteboard through your web browser. And in this dashboard, we are going to start some discussion with the panelists, but then also thanks to the question and answer channel, the audience will be possible to ask questions. And then also inside this whiteboard will be possible to put comments, messages, share content. So we will try to do this part of the workshop more interactive, I would say, because I mean the main goal of this session is to get your feedback from your side and get some suggestion, and in order to improve all our first approach. Consider that BRAINTEASER is a project that started at the beginning of this year, so we are in the first phase of design, and we are applying what is called a user-centered design approach. So every type of feedback is welcome and will be used for the next iteration of the design of the services. So I ask to please send in the chat channel the link of our whiteboard in order to give also the opportunity to the audience to access through their browser. But also for the ones that are not able to access, I will share the screen. Okay, so I will share my screen. Test, share. Okay, and this is Miro. Okay, I will just make you some little presentation of this whiteboard just to understand how it's work. I see that people is starting accessing to this whiteboard. I can see, as you can see, there are some cursors that are moving, no, and yeah, so in this whiteboard, we will be able to leave messages, okay, specific messages here, your comments. You can press on this icon that I'm showing here on the left, or even you can put some notes, okay? You can even put some content, other contents, but I mean, I think that the most useful functionality to provide feedback is to provide notes or messages. No? Now I will start describing the first overall approach of the design of our system. Then I will start a discussion with the panelists, and then we will go more in details on the presentation of the solution, because also we have some example of screens, no? So I hope that all this material will trigger maybe some discussion with the public and also with the panelists. Okay, so let me just introduce what is more or less the status of the service design. No? So we want to create an app for MS and ALS patient, an app that for sure will be personalized, and an app that will have a big challenge in terms of what we call user interaction, in the sense that we want to create an app in which it will be possible to interact with different modalities. This will be personalized according to the impairment that the user will have, no? According to the progress of the disease. So we are considering for sure the typical interaction using the touch screen of the mobile, but also to create some accessibility functionalities in order to increase, for instance, the contrast of the screen, to increase also the the length of the dimension of the button, and also to interact in another type of way, like for instance by voice, or using also a head armed sensor that will allow an interaction without the use of the screen, the touch screen. So first we have this type of approach. Then we consider to design an app that will be used as a daily companion for the patient to receive support and also to provide information to the health professional. And at the same time, we would like to give to the user a wearable device. We are thinking to buy some Garmin wearable in order to also track some physiological data, some activity data. The physiological data related to heart rate, temperature, and meanwhile activity data related to physical activity whenever it's possible for the user to perform activity, stand activity, and also sleep patterns. So in the app, we would like to provide also the support to create, to answer to questionnaire. Then we would like to provide the support through educational material for the patients and caregiver. We would like to have also contact functionality to be in contact with health professional, but not only health professional, but also to contact, for instance, other the patient association, or for instance to contact other health professional and send the material, all the data that have been gathered in this system. We would like also to provide some support to perform part of the rehabilitation exercise at home whenever is possible, and also to provide some support to emotional distress, for instance, providing some mindfulness content. And then also in order to, we would like to provide some support also on the cognitive exercise by creating some cognitive games. So all this information that we are going to gather through the app will be used also by our artificial intelligence model to create a model of prognostic and model of the risk assessment. All these type of information will be used also in a clinical tools that will be used by the health professional. Especially, we think that this will be a tool for neurologists, for nurses. And thanks to this tool, we'll be able, the health professional will be able to remotely assess the health status of the patient, and the system will help to digest all these data that have been gathered, and will be able, thanks to the models, to generate specific alarms for the patient, in order that the health professional will be able to put attention on specific patients, like using a sort of traffic light approach. The patient with the red traffic light will be, the ones that require special attention. And thanks to this, we will start triggering new clinical processes of follow-up of the patient. Imagine that thanks to this tool, maybe the health professional will be able to anticipate a follow-up visit because, for instance, a symptoms has been reported. So this will allow, we hope that this will help to improve the management of the patient, thanks to this remote management, and also will help to give more information, provide a more accurate assessment on the user, and also to support the management of the relapse by an early management of the relapse. All this technology for sure will be enhanced by this AI model that will provide this timely information about risks and prognostic of the patient. So this is basically what is our system. We will have an environmental part that Arianna is going to discuss later. And now with this first presentation, I would like to start a discussion with the panelists in order to also break the ice, no, say, in this workshop. And so I have one question for the panelists, no? So but first, what do you think of this approach? But in general, how digital technology can help patients, no, to have an active role in the disease? What key services we should deliver? Now, here you have an example, but most probably we are missing something, or maybe there are other types of approaches. So I ask this to the panelists. I don't know if somebody wants to intervene, or otherwise we can make a round.
Okay, I can start if it's okay for you.
Yes, please.
As I said earlier, it's very close related to the two projects, yours and ours, BRAINTEASER and Alameda. We also thinking of using wearables, but not using any medical records from previous medical records from the patients, because it's very hard to get, and also it's very hard since they are not digitized in most cases. So concerning your question, we truly believe that digital technologies can help the patients to have an active role, since they can input their data throughout the day and every day, and then the doctors also will benefit from this since they have and more reliable source of information. Since by the visit, during the visits of the patient to the doctors, many of the things that they have passed through the last 3 months or 6 months, they are forgotten by them, and they do not mention it to the doctors. So having a continuous, more or less, monitoring of some symptoms from some variables that are closely related to the disease, it's very helpful for both the patients and the doctors. And the active role I see for the for the patient is that they can also monitor their progression and how they correspond to the treatment, directly inform the doctors about any treatments, side effects, and etc. So I think that digital technologies, that's why we also, as you bring this project, is to help the patients have an active role in the disease and not just reporting to the doctor and then the clinician take his decision. In our case, we also feel very we take very seriously under account the engagement of the users, and through the designing, we also have 5 months now that we started the project. We have established an engagement coordination committee in order to give information to the patients and the caregivers about what we're going to do and how we're going to do it. And they give us their feedback concerning their acceptability, and also how they feel about it, and if there's something that they need to be changed for the design. I think that I all have to say for now, for this first question you asked, Manuel.
Yeah, thank you, Panos. I think that yes, this also your project is a very challenging project, and I'm very happy to hear that also you are involving the stakeholder and the patient from the beginning of the phase of the project. This is very important. Always a way to mitigate also the risk of low adherence and adoption of this type of services, because at the end of the story we need to create tools that are useful both for patient and health profession. Yeah.
Yeah, exactly.
I would like to hear also the opinion about these opportunities of the digital technologies, from Evi, Pedro. What do you think? Yes, Evi, please.
Well, I think that's my opinion, that this will be very helpful for ALS patients, because we see in some stage of the disease, patients are not able to travel to the clinic. So it will be very good to have such an application that they can just do this at home and still be in contact with the physician and giving all the details about their stage of the disease. So I think this will be good opportunity for ALS patients to be involved in this.
Thank you.
Manuel, can I?
Yes, please.
Can I join? MS, multiple sclerosis, has a lot of invisible symptoms, and the progression is not clear for patients and professional neurologists. I think this kind of tools could throw light to see the evolution, as Panos was contributing before. We need to know what is happening in the patients in the daily day, and it's very important for the patients to take decisions to change the treatments, for example, or to provide accurate information to the doctor. So I think making more visible and having a clear view of what is happening with the progression of the disease is very important to improve the quality of life of people with MS in the management of the disease. Also, probably some other kind of measurements about the risk of what is happening also in your body during this during the process of taking the drugs could also help the professionals. But for me, the progression is one of the things we need to we don't have enough biomarkers and markers of prediction, and we don't know exactly what is happening. We are trying to get information about this with prompts and questionnaires of quality of life of others to cross with MRI, for example, or others, because when the MRI shows that there are new lesions or something is happening, probably a lot of things has happened the last year before, and sometimes the conversation with the doctor is, I see you the same as the last year, but the patient is telling the doctor that something is happening in the body and he's not the same, and probably a little more fatigue, or he has stopped going with the friends or whatever, and we are not able to show what is happening there. So data collections and monitoring the daily life could throw light on the progression and what is happening.
Thank you, Pedro.
May I add something to what Pedro said? It's very well said. And that's why we need the clinicians to tell us, and we try to define variables that we can monitor through wearables or other digital tools, in order to monitor also not only the disease-specific variables, but also the non-disease variables, like their social life, like how they're feeling, and apart from their disease, and how they're sleeping, as you also mentioned in your project, how is your sleep. And these non-disease variables are something that needs to be also monitored and correlated with the disease symptoms, in order to have, as Pedro also mentioned, a better image of what is the quality of life of the patient.
Yes, I think I fully do agree that with the hub we have this opportunity not just to collect clinical metrics from standard questions, but also to monitor the overall evolution on the behavioral part of the user. And this for sure will could anticipate even physiological symptoms, so it's important. And then yes, for sure, the quality of life also is something that it's something that we are taking also into account in this project. Thank you.
Maybe, obviously, if we think in ALS, as Ivy has said, it's a very heterogeneous disease. So mostly our challenge is to figure out not how the disease starts and how it ends, but all the course in between the disease that can range for months to some years, with some bulbar manifestations on set, with some limbs manifestations on set, and sometimes a mixed control. So on ALS and multiple sclerosis as well, the symptom management for the clinicians, for the patient and for the caregivers is a very high priority in the daily living care. There is also the other part, that is how we can improve functionality and socialization in these patients and avoid isolation, that sometimes isolations can increase the loss of function, because it's like a vicious cycle, even for cognitive impairments associated to the immobility. So at this point, the management of the disease can be enhanced by telehealth technologies, for sure, during the disease progression. And at this point, these telehealth technologies may include multidisciplinary rehabilitation programs, because one thing that we here experienced with our community is that, for example, during this pandemic course, the loss of the routines of rehabilitation, of standardized care, actually increased the progression in some patients, or even the anxiety of not being able to be with the caregivers, the formal caregivers. There are some already telehealth technologies on that is widely used on ALS. Specifically, if we think on ventilations, there are some interface with the ventilators that can directly contact to the centers, and they can give information of usage, number of hours, apnea or hypoapnea, ventilation, volumes, and saturation if the patients have, of course. And this is already an increased task of the telehealth potential in the ventilation control systems. But the rehabilitations, the nutrition indications, pharmacological symptoms control, and also brain-computer interfaces like eye tracking or augmentative communications, to even be able to communicate and assess not even the clinicians, the families, and the socials, but also how ALS patients during the course can interact with the applications. This must be also need to be considered in order to the app be functional for the patient and the caregivers. We can see, for example, for Breathe or Toby, there are some Microsoft conjugative applicatives that can incorporate the app as a functional application for the patient and for the caregivers. And obviously, as Panos was saying, if we can readapt the function status during the course, obviously there will be a higher perception of quality of life, because there will be a readequation of the capability of the patient through the disease course, which is not possible without these tools.
Thank you, Philip. I think that, yeah, this is what you mentioned are very, very interesting specific functionality for ALS. And I think that the communication tools are very an important component. At the moment, we are focusing on this communication tool just for the app. But I mean, we have some experience on accessibility work in our university, and I think that easily we can also extend this type of functionality to augment, also to communicate with other relative and stakeholders of the patient. I think that it's very important, as you also mentioned, not to avoid the isolation of the patient. So also technology is not just a focus for the delivery of the care, but should be, I mean, a solution also for the daily life and daily problem of the user. No? Yeah. I think that maybe here will be an opportunity to have this mixed approach, for the clinical follow-up, but also for the to face the daily problem of the person. Okay, thank you very much for your precious feedback. Some of you mentioned also the caregiver. I would say more the informal caregiver, the family and relatives. As you can see in this first sketch, since we are at the beginning of the project, we have a lot of tools, a lot of issues to discuss, but we have in mind to create some tools for the caregiver, for the informal caregiver. At the moment, we are thinking for sure, to provide them some information, okay, to give, to prepare them, to how to provide the support to the patient, but also to monitor them. We would like to measure the burden of this of the caregiver, the informal caregiver. So also in this case, I have one question for all of you. What about what could be an interesting use of the digital technology also for the caregiver, aside from this information delivery and maybe some questionnaire to measure, to assess the burden of them? Do you think that we can maybe create other type of specific services for them?
I think I will jump in. I think that for caregivers also, the coordination with a multidisciplinary team is very important for them, because not only information, but also taking decisions with an overall vision of what is going on, or have a complementary information when it's needed is important. So I think getting caregivers also connected with the patient organization, the hospitals and other stakeholders could be interesting for them, not just getting information.
Thank you. Yes, to not just to provide information, but to involve in all the clinical process during the course of the disease, in order to,
or something like a helpline, or something to push when you need some immediate information, or if you need to get some support, or whatever other kind of coordination needed. I think it's important not only to send in one direction the information, but getting a bidirectional or multidirectional collaboration between caregivers and others.
Okay. Yes.
Yes.
Even.
Sorry.
I agree with Pedro. It would be very interesting if it would be possible for the caregivers to have this triangulation with the physicians or the clinicians in order to provide or signalize the need for help, especially on ALS when there is a rapid course of evolution. But one thing that might be also important or interesting to discuss might be the availability to have different caregivers profiles for the same patient. Sometimes patients do get this dependency with the same caregiver, for example, husband and wife, that they get easily attached with the comfort, the specificities of the transferring, hygiene, routines, and sometimes the application be able to inform other caregivers, be able to schedule other caregivers, or to even make possible to get some notes of how to do, how is the best routine for the patients in between this inner circle, might be something very interesting for the the management of the patient's needs and the release the burden of the caregiver in order to give some notice, receive some notice, know that everything is okay, like a checklist with in between the other of the familiarity circus. That would be, in my point of view, interesting. Also in this part of the application, I don't know how you are thinking, but if we think in some caregivers or in some families, the app might be challenging in order to use or to utilize. So some formation course or some basic guidance in order to fully beneficiate the power of the app that you are constructing would be nice or useful for the caregivers, because one of the things that they usually tell us is that they don't have free time or much time, so the app cannot be seen as another task to do, but a facilitator. So this would be something to consider when we are constructing the app.
Thank you very much, Felipe, for your feedback. Yes, on that, yes, our first approach was okay, very simplistic, but I think that with this feedback, we will start also considering a more interactive services for the caregiver in order to give this support, and also to, as you also suggest, to be able to give that, to check that the caregiver provide all the required support that in many cases is multidisciplinary. So you mentioned like a checklist, and I think that this could be very, very interesting. And then also for sure considering, as you also mentioned, this part of the time of the caregiver, that also this is with very very proportional also to the burden, because if the caregiver is not feeling to have a time for him or herself, this is starting generating also a personal problem of the caregiver. So thank you very much for this feedback. Does others have any other comment on that about caregiver services and opportunities with the digital technologies? If not, I will go. I have another couple of questions. One is related to the study that we are doing now in this project. Now that we are trying to create this remote procedure to assess the user. And as I told you, there is this application that is able to collect data through questionnaires and some question, and also to provide other type of information as physiological data, thanks to the wearable sensor. And at the same time, we are going to provide some information to the user, but we would like to understand if maybe we will be able to create other services to being able to assess. I would say services that are mostly related with the new technologies, because these are more standard way to assess a user, through lab test and through questionnaire and observing the user. We are doing with the technology remotely, but it's quite similar. It's not the same because in the clinical environment, we will have more powerful tools for sure. But do you think that is there any other type of approaches? We were thinking on, for instance, to creating self-evaluation test, for instance, using the touch screen to assess the dexterity of the user, or maybe other type of test using face recognition. This for sure will be not standardized test, but in the frame of this project, we can maybe try to compare with standard metric and standardized. Do you think that will be possible? Do you have here something on that, some experience on, I would say, novel procedure for the assessment of the patient using mobile technology, for instance, or other type of technology that we can bring at home? Before Felipe mentioned like a ventilator solution for remote management, no, right? This is a tool that, I mean, is like an IoT devices that is providing remote information for sure, but maybe also using the sensor of the app or other type of sensor. So what do you think on that?
Yes, may I start?
Yes, please.
Thank you. So since our project is basically based on only on digital sensors and digital input from the users, we are also considering of using conversational agents with the patient, some chatbots instead of questionnaires, and also we believe that a cognitive game will be very useful. That in this this case, we are having 3 use cases in our project. Apart from MS is for Parkinson and also for stroke patient, and we are going to use this game in order to monitor and assess the cognitive status of the patient.
Mm-hmm.
This is a virtual game from our partner, and we also modify and adapt to the needs of the patients an application that is used by athletes for having their nutrition, daily habits, their exercise habits, to monitor those daily activity, let's say, habits, and also there are some questions that you also mentioned, and an AI, let's say, virtual assistant that will help and promote the eagerness of the patients to do something, to work for a longer time, to go out and have a nice and well-established social life. Additionally, since you are also mentioned the face recognition, we're thinking of using emotional recognition during the engagement of the patient just at that time with the application of our project, and try to see their emotions and have a more objective measures for their psychological status, let's say. So I think these tools also that would be embodied in the same application, that will help us to have additional inputs that can be used for assessing that those data will be used for assessing their lifestyle data, their daily activity, the psychological assessment, and also to daily monitor the patient status concerning the disease-specific issues. Another interesting thing is that all those sensors, let's say the smartwatch has a lot of sensors embedded in this device. And we are going to use, we have also identified some, with the help of our clinician partners, some variables that can be brought together and fused in order to make assumptions and predictions, if I may, so some predictions of several concerns of their status. We have already identified 5 domains for the for the variables that we are going to monitor. The first domain is the performer for the mobility and general motor function. The second domain concerns the sleep disorders. The third domain, the mental and the cognitive ability. The emotional status is the fourth, and the fifth is the quality of life in general and the daily living. So all these tools will be provide us data. All these tools you mentioned, and I add some more, will help us to monitor and assess those 4 domains of variables and needs that affect the quality of life of patients. I hope it will be that was informative enough.
Yeah. Thank you, Panos, to share. Your approach in the project, in the Alameda project. Yes, I think that most probably this is something that we are discussing internally. But yes, as you suggest, so this approach, mixed approach, to try to gather from different sources a different dimension of the user, no, from the daily life. From quality of life, from sleep, emotional distress. This is something that we are considering in this case. You mentioned a very interesting also user interaction solution, that is the chatbot, that at the moment we are not considering this type of interaction using natural language. We are considering an interaction with the system using a structured menu. In a way, the user just report by voice or using head, armband, or the touch screen. No, report. So I think that yes, you provide a very, very interesting suggestion for how to improve the system. And this, I will bring all these suggestions also to the consortium to discuss them and check feasibility. Thank you so much.
I have to mention that it was we had a very long discussion with the clinicians in order to to try to match their questionnaires, their clinical questionnaires, to the sensors output, and it was very difficult, and it is very difficult to match those variables in order to see how you can get those information instead of questionnaires from other sources.
Yeah, we are more or less in the same page. We discuss a lot internally the questionnaire. We have a first version that also is present in this whiteboard. Then I will show you what we thought about what are our first approach on questionnaire, standard questionnaire. And then for sure we need to make a work to optimize this at least in the part of the patient app, no? To try to minimize and maybe leverage more on other types of approaches, no, like sensor. Okay, do we have any other feedback from the other participants? Felipe, Pedro, Evi?
There are some gadgets that sometimes we can use for a short period of time, like pedometers, or the watches that have these anti-fall systems. When a person falls, he directly contacts to a number of referencing of emergency, then to a second one, or to the national number. Our problem with these gadgets, it's normally the heaviness of it on the arms of the patients. We are progressively losing the strength of the elbow and wrists, and usually that is the main reason for the dropout of the use of these gadgets when they are considering home care assessment of the risk of falls, or with the dislocation, like a wrist pedometer. If it is in the pocket, it is okay. There are some things that might be interesting for the patient or for the caregiver that I don't know if it is possible here in the scope of this application, but it's interesting to discuss. When you talk to identify relapses and to provide an effective remote assessment, it would be, I don't know if it is possible, but it would be useful to to be able to provide some images to the clinicians or to the reference. I am thinking about, for example, skin lesions, posture, the need for some technical aids and supports, or for assess the way that the patient use the app in order to not drop out, because you put some images on the left side with a headpiece master, and sometimes it might be a good solution, other times it might be not the best solution. So that would be interesting for the patient to be able to provide the application people that are working, or even the clinicians, in order to best use it, or to be able to continuing to use it. An interesting thing that you ask for me as a physiotherapist is that the use of scales or other objective instruments, they are standardized, and maybe what this app might facilitate is to, in the first part of the use by the patient, if it's ALS or multiple sclerosis or even other neurological diseases, it's a deeper analysis of his routine. What he can do, what does he do, what are the list of activities, how many times, how long does it take to dress up, how long does it take to eat, like from eating, from dressing, for hygiene, from working, if he's working, how does it work, how does it enter the car, how does he go to the work. The best, the better, because it will be the first assessment. And even with the panels was saying the question of a first cognitive assessment, like semantic memory, short-term memory assessments, association memories, mnesic tests, that would be interesting to have this first picture of the patients. For me, this could be interesting, because then we have a profile of the patient. Then we can replicate by the app at home 1 month after, 3 months after, 6 months after, when it's orientated by the physician, the neurologist, the clinician that is working on the field, in order to assess the needs at home care. And this would be very interesting, because you would be able to have feedback, objective feedback by the sensors of your app, its location, time outside, sleep quality, meters that patients walk, or a daily activity, but also a profile, a comparational profile of his scores in between the disease course. And if there is some loss of points in some specific field, some applications, functionalities could be highlighted in order of the others. For example, if it's a problem of walking or going outside, some functional activities or exercise might be prioritized. If it's a problem of cognitive participation, some cognitive daily exercise could be indicated for the patients. I don't know, maybe a feedback feed-forward loop would be interesting in this area.
Thank you, Philip. You give a very, very, very interesting feedback. I was thinking on possible model, to associate the real impact, of a relapse on the daily life, and use the scale that you suggest, that are mostly not standard scale, but based on daily user activities, to understand the changes on the daily activities, and also correlate for sure with standard questionnaire, or even physiological measurement. So I think that this is would be very, very, very interesting. So I was thinking that maybe we can add also periodic procedures of assessment. That this would be less standard, I would say, according to other type of standard scale that there are. And maybe also in this project, we can then do also the work to try to find this correlation. That I also think that this will be more sustainable for the user, to report times of activity rather than more standardized question that somehow is quite frustrating, because you are thinking on the disease, and this is the problem of the health apps that always remind the user that they have a disease. You know, this is a paradox, but I received this feedback with the patient in different fields, from cardiology to mental health, neurology, cancer. Always the apps for health helps, but remind the user that they have disease. So with this type of suggestion, this one and also the previous one, to, for instance, provide also services to deal to face with the daily problem, I think that we are humanizing more this type of systems. So thank you very much for this feedback. I think that they are very, very precious for us.
May I also add something to what the previous speaker said, is not to add any other tool, just the use of the tools, so that we are both going to use, and everyone else, is the time and the timing of the questionnaire. Let's say how many times a week, how many. It doesn't. It should not be a burden for the user, for the patient, just to have to answer 4 different questionnaires every day, to make some tests every day. So it's very crucial to be patient friendly, the application and the monitoring of the patient, so that they do not drop out. They need to be specified by the clinicians and also by the technical partners. Also, the time and let's say for a smartwatch isn't something that can be continuously monitoring. It's something that will press the user to use it, or increase the anxiety or something. But for making some, for doing some specific tests, like a 6-minute walk, or asking or answering a question or something like that, it will be a burden for him to do it every day or 3 times a day or something like that. So the timing and the frequency of those tools that will be used to get data, to get information from the patients is also very crucial. Something that we have to have in mind.
Yes,
indeed. That was something I want to comment also. We need to look for the time for the patient, what it takes to go through all these questionnaires. But also on Felipe, I want to comment. We need to, in Belgium, we call it like, we need to be a little bit careful that it's not going to be Big Brother, because patients need to choose when they want to be followed or when they want to have their sleep be measured, and not that it's just a standard of procedure actually that is going to be measured. So they need to have the choice to do it.
Yes, I do agree. Thank you, Eddie, for this feedback.
Manuel, I have a comment on current technologies. I think it would be interesting to explore that there are a number of applications created by pharma companies in the multiple sclerosis field. For example, Roche is Flute-like project, there is Biogen, there is Psychometrics. They have a number of different apps measuring the different data from the patients. They are exploring a lot of new possibilities. I think instead of creating new ones, probably we can engage with some of those technologies to make a collaboration, or for example, in this kind of project. I am thinking also in Psychometrics, for example, a new development tool, for example. So it's not one, but at least 3 or 4 pharma companies that have several apps and tools that are collecting data. For example, there are also a project from Novartis it's called FitMe, collecting data from for the data from the zoos, putting a plant, I don't know in English the word. So there are lots of different experience there, and I think we can also explore that engagement with those.
Okay, thank you. Thank you. Okay, I have just the last question now. The last question is mostly related to the artificial intelligence models, because we were thinking, I mean, this project aims to create these prognostic tools and risk assessment tool, no? So we are discussing this potential use in the clinical settings, no? We expect that most probably these prognostic tools, if they works, will be able to maybe anticipate, some clinical process. But we want to maybe discuss with you about these types of the use of this type of services, because really, for what we saw, I mean, there is not any type of solution working in this direction. So, what do you think? Do we have some risk? Do you think that might be useful? What could be the clinical use? And then how we can then also deliver this to the patient? No? We consider at this stage that the first feedback will be given to the clinician in order to avoid any kind of misinterpretation of those risks of this prognosis. But then also somehow these should be communicated to the patient through a clinical process. No? So what do you think on this use of the artificial intelligence in the clinical practice? How do you see, what are the risks, what are the benefits?
Yes, the benefits for the doctors or the clinicians would be that they have an objective view, much better and objective view of the status of the patients during their daily life, and the data that will be processed through the AI tools will be multimodal from various aspects of life and treatment and rehabilitation of the patient. And they will give them some information that, at least to my knowledge, they don't have it so far. They don't have daily monitoring of the heart rate, let's say, or the sleeping patterns of the patient, and how all this affects their emotional status. So there can be an alerting mechanism for the doctors, that it will be say, for example, that the patient is having high anxiety or feeling depressed through the last week, because he also doesn't have a good sleep, and he's feeling very fatigued. He's not doing his social life as usual, and other things. From the patient, it will be the same but different alerting system to tell him her to promote their social life, or maybe inform him that all those symptoms, that all of those let's say decrease of their quality of life is maybe a subject of sleeping or of treatment or of something like that, and he should consult the doctor instead of 6 months that he's already arranged an appointment. He can do it earlier, and also the doctor be aware of that. I think more or less this is, and also for the AI tools, it's very crucial to have the risk is to identify early and define correctly and strictly the medical question that we have to answer. We cannot cover everything with the same tools, at least for now.
Yeah.
So it should be defined very well, and so as to provide information concerning this medical question, and not everything about the status of the patient.
Thank you. Thank you, Thomas.
Maybe to add to this topic of risks is something that when patients need to answer questions, you don't know if they are answering actually with the whole truth. When you have a face-to-face conversation and you ask the questions, you can see if a patient is honest about his or her answer, and you can go more to depth. And with doing this via an app, it's more difficult to get clear if the patient is honest or not.
Yeah. So we have like a challenge to promote in this remote monitoring, because it's different. The reporting is different if it's in the app or is it through the face-to-face, for sure. Yeah, it's we will add the bias, and we try for sure to try to manage this. But yes, I think that this is a problem of many mobile health solution. That is there is this added bias, because of the situation, because we are not in the hospital, we are at home, and then according also to the burden, to what the activity required by the app could be a burden, so people is less motivated or not. So yeah, I think that this is a risk that we should try to manage. Also, there is another problem that we experience in other projects, that is the definition of the reporting. For instance, there are questions that how do you feel? Happy, what is your happiness for you, and what is the level of sadness? These are not objective concept, so user in many cases need to have a support of a definition of what is, for instance, the grade of a symptoms. It's the yes, thank you for this, because it's something that we are struggling in other projects, but also in this we are going to struggle on that type of risk. Thank you. Felipe, please.
Yeah, maybe one secondary utility for this application, if we think about the clinical use of these models, might be the use of it when the patients, for example, I'm talking about the reality here in Portugal, but when the patient is referenced for some healthcare provider, some institution, some hospitalization, in some agudization point of some care, there needs to be admit in the facility care. The information of these applications might be very useful for the new healthcare providers that don't know the patients and their routines, to get some sense of what you like to do. I'm thinking in ALS patients because there is this difficulty of communication and sometimes mobilization in order to provide, and is associated with some fear of hospital admissions or reference for home care, nurse home care stations. I know that in Belgium it's a little bit different, or even holidays for the caregiver rest that sometimes we are able to perform. And this would be very interesting if in some way this report can be useful for different caregivers, formal caregivers, in order to give information about the patient, that this is how I like to do, this is how I do, this is what I feel comfortable mobilize these things, this is my type of things that give me joy and comfort and are prioritized. Would be a secondary skill of the app that would be interesting in my opinion. Other thing that might be interesting in this field it's the availability of a quicker differentiation by again here in Portugal by the clinicians of the needs to provide technical aid solutions for the patients. Because if the patient is not walking as much as he do, is having some change in the task that is evaluated by the applications. Maybe some technical aids or product must be evaluated and prescribed as early as possible for the patients in order to correct it or maximize its function. So these are two possible positive clinical uses of this model of application.
Yes, thank you. Thank you. The first comment is very interesting, no? Because for sure this can help. So it's as also you commented before, no, about this role of the caregivers, this multidisciplinarity, also the complexity of the management, and maybe also the change over time of the caregiver, because maybe you are starting involving new figures in the process of home care of the user. I think that you really suggest very interesting functionalities for provide like a sort of overall profile and preferences of the user. Yeah, I think that. Thank you so much. Do we have any other comments on the potential use of the artificial intelligence?
Yes, may I also comment on that to what Evie said about the objectivity of the answers of the patients to the questionnaires? Is that using AI that we can use data coming from different sources, from wearables, from social activity, from other questionnaires that can also be combined and let's say tackle with this objectivity issue. We can combine information from several sensors, and we can find, hopefully, the right response to if he is happy or he is not happy. If he said that he is happy and we see that the social life is very low, he's not meeting anyone, he's not talking to anyone, then it's not something that he is happy or something like that. This can be managed through the AI model that will be specific, let's say, developed for the status of the happiness of the patients, for the emotional status.
Yeah, and yes, at the moment, the main focus, according to what were the objective of this research project that has been funded by the European Commission, were to create a prognostic model and risk assessment models. But yes, for sure, we can, as we start having data, maybe create other type of tools that estimates other more complex dimension, like emotional status, considering other type of variable. Yes, this is something that we will discuss, because there are, for sure, having the data, of certain quality, most probably will be able also to do more than this type of risk assessment and prognostic tools. So thank you very much. And do you have some criticism on that? Because this workshop are nice also to have some criticism, because always criticism is welcome, because we are doing research and we need to have also this type of critical point of view on that. Do you have some feedback or maybe limitation barriers that we can have on this type of models?
One criticism that is also applied for us is the ethics of of using those models. What data can be used? If we can, let's say, for example, can monitor their social life through the smart devices, monitor their face even with their consent, in order for doing emotional recognition with facial recognition. There are several ethics issues concerning the AI and how the data will be used, and what is who has the ownership, which is the patient, of course, but maybe the patient have some concerns about that.
Yeah.
Yes. Yes, please, man.
Yes, in this project, we are managing very sensible data. Yes,
Yeah.
for sure. And then also, in this project, we are also now we are going to go to another interesting element of this project is the part of the environmental sensor, in which would like to study the exposure that are also related to a very sensible information that is the localization of the user. So in this project, we are trying to address all these ethic issues because we are managing sensible information. And then at the moment, I mean, for sure, we give the freedom to the user to accept or not the management, the collection of this data. And then for sure, according also to the GDPR, in our case, I mean, is the context of use. In our case, I mean, it's just for the to try to estimate the evolution of the disease and the risk. So we hope that patient might accept, but this is, I mean, something that we still need to verify with the next rounds of this open design session that will be with the patient, and in which we are going to present all the information that we are going to gather. For sure, we are taking into account seriously this part because we know that under the acceptance point of view of the users, I would say, but also for the legal point of view, and also for the IRB committee, of the hospitals, this is taken also seriously. So we are trying to set up an architecture that is able to manage this type of data, and we are also going to create all of these procedures under the legal point of view in order to be compliant with, to the regulation at the European level.
So maybe it would be interesting and thinking about what Eva has said before about how much the patient is willing to share, how much the patient is able to use this complex app or ideas for the app. It would be interesting if the app has this versatility of how much information can be presented to the patients. Otherwise, it might be difficult for the patients and the caregivers to engage in the app with this all information that is here, especially if we consider different types of patients that are more familiar to interfaces, patients that are not familiar at all with this type of applications. And if we think, for example, in a patient that is admitted in the hospital after a diagnosis of ALS for the first indication to the neurologist or the multidisciplinary team, if we presented too complex app that talks about symptoms, that is focused on the disease and is not focused on functionality, it might be this counter side that is the dropout, and the patients don't want to know about the app or the disease course, or they just don't want to know about it. So the first thing about this would be, for me, some capacity to transform the app from a lighter side of the usability, focus on functionality, and now we can be able and then cluster the different patients, neurological patients, ALS, different phenotypes, multiple sclerosis, different phenotypes, other neurodegenerative disease, and be able to construct it after that according to what the patient is willing to accept in ethical terms.
Yeah, thank you, Felipe, for this very, very, very nice feedback. We are trying to address this because we have more screens of the app. I hope that later we will be able to just have a quick overview, but we have an enrollment process in which we would like to try to personalize this system according to the real user needs, and also personalize content and services. And on that, also according to the willingness, for sure, according to the condition, okay, or stage of disease, but also according to the willingness of the user. No, if the user is feeling that, for instance, tracking location might be useful to have the exposure or giving other information from question that can be useful, we can activate those modules. In other cases, no. So the system theoretically can be like simple as to wear a device, wearable, or can be even with an app, or maybe user just use the app. So that's the idea, is to try to create this as much personalizable as possible, according to needs and for sure engagement and willingness to use. Thank you. If for you is okay, I will move to another element, no, that I briefly introduced before. That was this part of the environmental sensor, and I will move to another little sketch that we have for the project. And I also ask you, Arianna, to maybe lead this part of the conversation, because Arianna is working directly on this setup of the environmental and exposure model. So please, Arianna, can you give us an overview of what we are doing in BRAINTEASER? What is the plan?
Thank you very much, Manuel. As introduced before, what we would like to do in BRAINTEASER, it's to integrate into the model of disease progression other information regarding the exposure of a patient to environmental factors, including and mainly air pollution. So to study this possible correlation, what we are planning, it's to leverage on one side to some existing infrastructures that are already available in the cities where we are carrying on our studies. So for example, sensors through the city that have been installed by national environmental agencies, open data, and also for some city we already have some dense grid of networks made of commercial sensors. And then there is another part of the project where we are going to install other sensors. So other sensors that can be installed at the home of the patient, or that can be portable. And what we want to do is to create this dense grid of sensors also that take into account the kind of patients we are going to monitor. And the final aim is to build these trajectories of exposure to pollutant, which can be very precise, and that can be integrated into the artificial intelligence models. So this is more or less the ideas that we have, and we would like to discuss these more in details, especially with Ata, who's an expert in this matter. So Ata, if I have like a couple of questions for you. The first one regard the environmental monitoring. So as I tell, what we want to do within BRAINTEASER, it's to build this sensor network to monitor the exposure from air pollutant. And in your opinion, which are the best practices for the deployment of these networks? For example, how these networks should be constructed in relation to the urban morphology, which are the best granularities for construct these networks, and which may be a good level of integration of these different sensors.
Yeah, thank you, Arianna. It's a very relevant question, because also for our project, Emotional Cities, we are also exploring the same, let's say, domain. And I think this graph that you have here, it gives like a pretty good indication of what I wanted to say, because I want to divide this whole topic of environmental sensing under 3 headlines of scale, method, and metrics or measures. And for the scale, as you showed here, normally in the most of the municipalities or the departments that they deal with the environmental, let's say, measures in the cities, they have this network of sensors that they collect data. Maybe, I mean, for example, in Munich, I know they have from the city, we have 6 to 7 to 10 scattered, let's say, stations that they collect the environmental data. But then as you see, when you map it, you have a very, let's say, low resolution distribution of air quality measures, which this doesn't necessarily connect to the people's exposure on the street level. So that's, and then the other thing is normally these data is collected just to have this sense of air quality. It doesn't have any specific reason. It doesn't connect really to the people's daily activities. Of course, it gives some indications, but it's not very high resolution location based. And so if moving, and that's mainly on the meso scale, on a city scale. But then if you move to micro scale, where we call it microclimate, that's where we specifically work on, we call it 2 meters of air, the 2 meters layer of air that people have their constant interaction with it on daily basis. And that's where the variable sensors, or I would say the mobile sensors, they come into, they become more important, because then you can give very high resolution exposure data, spatially and also temporally. So these kind of sensors, normally it can be carried. I mean, there are different practices, I would say. Some of them, they're wearable or let's say mobile little gadgets that people can carry, and then they record the air quality measures. And then I think that the best practice is that to combine these both, let's say, scales. You get an understanding of a meso scale on a city scale, and then you zoom in and then collect information on the micro scale. And I would say it makes sense. That's what we're also exploring, to combine these two, combine sensing with modeling, with computation. That could be the backup. For example, because with these variable sensors, it's really difficult to map the entire city. But if you have an understanding how the urban morphology or how availability of green space or parks, they affect the distribution of, let's say, air quality measures or even heat stress. I don't know if the heat stress is also a topic for you, because we also explored this topic of heat stress exposure in summer beside the air quality measure, that they can both combine to this fatigue or not even willing to use the outdoor spaces. So this can, so combining this with the modeling, it can bridge this gap that you can expand or upscale your microclimate measurements in connection with the meso scale or this open data connection.
Thank you very much for all this suggestion. Indeed, having these different scales, so where we can move on and different granularity. It's a concept that we will surely take into account. Also, as I was introducing in relation to the different kind of patients that we are going to enroll into the project. So I don't know if maybe the other panelists have any comment on that, but the next question may be of a broader interest, because it will be a little bit less technical, let's say, and but still, if you can intervene on environmental risk. So, and on what are effective way to communicate environmental risk, also in order to avoid user frustration, because, for example, we know that if we communicate to a subject that he or she lives in a very pollutant area, it there's nothing that this person can do. So that might increase the frustration for that. And we have some discussion on how to present this kind of information to subject, and and this is also very much connected to Philippe's comments. I think so. Which level of information the display? So I don't know if you want to intervene on that.
I mean, I may start and then maybe we follow up. The first thing I think is the metric or the measure that, I mean, to find the real threshold. What is good? What's bad? What's the, let's say, the borderline that should be avoided by the patients? Like if you talk about, I don't know, particulate matter or NOx exposure, is it, I mean, it's also, one is the doses, like the daily doses, like if you say they shouldn't be exposed more than 2 hours, more than 1 hour. I don't think, I mean, I don't have any reference to say that this is, where is the limit? Like it's gonna be harmful for the patients. I mean, of course we can say always less is better, but what's the borderline that say, okay, if you have like 1 hour, it's okay, but if you have 5 hours, it's not okay every day. So I think the one is the metric, and then when we have the metric, when we understand what's the threshold, then we can start giving suggestions. Or, I mean, this is more, I think, connected to the behavioral aspect, because this is my own like interpretation or understanding. I don't think living in a polluted area is a problem. I think the problem is when you are moving from, I mean, I'm talking about the outdoor space. If you're going to work and if you're moving from A to B, what's the right path, or what's the right, let's say, navigation route that you will be the less exposed to these conditions? I mean, that's what I think makes more sense. And then if you can give suggestions that, okay, look, today you're gonna walk a bit, or you're gonna bike, or you're gonna drive. I mean, driving is not very relevant, but if you walk, you're gonna walk maybe 10 minutes more, but then you have like exposure to this, to, let's say, air pollution, or you're gonna have 10 minutes less heat stress. So I think it's, for me, it's more in the macro scale than thinking in the neighborhood scale, that if I live in a pollutant area, because indoor, there are many ways to control this. I mean, the problem is the outdoors, that we don't have a lot of potential or possibilities to, let's say, improve. I mean, there are improvement mitigation approaches, but in a personal level, I think that could be one strategy to in order to avoid this frustration or not willing to use this platform, it's better to give suggestions. So it's not giving them like, oh, you're living in a polluted area, so what's next? I don't think there is any next. I think it's better to provide alternatives or suggestions that they can pick through them based on their own willingness.
Yeah, so to be propositive, and indeed, I don't know what you think about like the idea of giving like portable sensors to the patients. That was something we were thinking about, and we were like let's say exploring this possibility, of course. So I don't know if anyone of the other panelists would like to intervene or have any idea on how this kind of data might be integrated into our model and into our application in order to be relevant for MS or ALS patients.
This is out of my scope, but thinking about what Ata and you, Ariana, were discussing, if I receive this information, it would be very difficult not to have some negative interpretation of it. If I have this terminal disease that is with no cure, rapid progression, and this somehow I am signalized that this is not the best environment for me, I'm very vulnerable to this information and could lead to misleading actions that are, the thing is, if we put it in the balance, what is the benefit and the harmfulness of it? So the only thing I can look at this as a physiotherapist and as a potential benefit for the patient is if this comes with practical informations for the patients of how to do or how to increase and potentiate the best quality of life indoors or outdoors. Imagine outdoors, it's okay to be outdoor with this and do X activities. It's no problem for this, avoid this. It's okay for this, avoid this. Otherwise will be, I think, maybe a vicious cycle to the downside of the scale, because this community is very vulnerable to this type of informations that can quickly escalate to misinformations and even so opportunistic approaches from other persons that can catch this and say, okay, so your app says this is not okay, so we offer this, and might be dangerous in some points.
Sure. Also because just to remember what we are going to do, and that will be like a huge part of the work before, it's to assess the correlation in between like the exposure and the diseases. Indeed, if for example for MS there are like some evidences of this possible correlation with air pollutant and the disease progression with ALS, we don't have really this kind of information. So a huge part of the work, it will be to study that and then to go through like a scientific publication, and then we were like indeed considering if then share also this information with the patients. But before doing that, of course, we are going to assess. We need to assess other things with our models. Okay.
May I add something?
Thank you.
Concerning the information that you can get from, especially from the wearables, let's say, and from the private and public sensor that you saw on the screen now, is that you can provide information to the patients for their psychological, let's say, explainability of why they are feeling now fatigue, because they are working 15 minutes in a lot of heat. And they can explain why they feel those symptoms. It's not something from their disease, but it's something from the weather and the pollution and something like that. Something that will help them feel better. That is not caused by the disease, but also by the environmental factors.
Okay, yeah, that's a very useful feedback indeed. Thank you.
It's not my sector, but just suggested.
No, but it's absolutely. I mean, we were discussing indeed like about, for example, humidity and how this condition. I mean, for like going for a walk at noon during summer, it's.
Because even not diseased person doesn't feel very well with great heat and high humidity. Yes. So it's something very rational to feel not very cool, very okay with that.
Okay, that's great. Thank you very much, Manuel. I think yes. I can leave the floor back to you.
Yes, thank you very much for this discussion. You see, this part of the environmental monitor is quite novel, and we would like to push a bit this type of research for both diseases. And yes, I think that now we have this last 15 minutes. I would like to check if there are any questions. I don't see any question in the chat. So I invite all the partners, in case that the participant, in case that they have some questions, to please trigger now. Now it's the time. Otherwise, I will we focus a lot on the overall system approach. No, so we discussed this first sketch of the architecture of the services that we would like to provide. We discuss also the wearable part. Now maybe we can make just I would say 5 minutes overview of what we have in mind. We have more details on what is the hub solution. So we spend just a few minutes just to show you what we are doing. and then maybe then we make a little conclusion, a recap, and then we can make also a final photo with the panelists with the video, in order to also have a memory of this event, and we can share in the social network. So for the app, I show you before the main functionalities. We have these 3 ones because we want to keep the menu very, very easy. But then you can, in the My Health area, there are all the information related to the user, to the health condition that can be gathered at home. Activities are a list of suggested activities for the patient. Those are one are personalized. At contact are the most, but the functionality related to communication with stakeholders. No, for the My Health, you will have like a list of possible functionalities related to symptoms report, related to periodic questionnaire, the medication in case that user takes some specific medication. Then we have some information related to exposure to pollutants. That is the ones that we are still on discussion, because the feedback also, as we understand before, could be critical. And then we have some information for the wearable data. In the home page, coming back to the home page, we have this section that is dynamic content. It will be the more interactive part of the app, in which the app will suggest what to do with the app. Please fill a questionnaire, or we recommend, for instance, an activity. So this is the dynamic content part. That will be like an animated part, which will be interactive. No? So the user will be able to go to a specific session or just follow the suggestion of the app itself. Okay. So regarding the question, before we discuss question that could be a burden for the user, and here we have a table that you can see for multiple sclerosis and ALS, and we identify scales, no, that for the clinician are very useful. And as you can see, I mean, we don't have questionnaire on daily basis at this stage. Maybe what we can do is on weekly basis perform an assessment, as Felipe suggests, no, mostly based on daily activities rather than specific disease situation, you know. And this is, I think, that's something that I will push to add, because I think that's very, very useful. And so we hope that this app, since we would like to have a long-term usage, at least 1 year in the study, then, I mean, as a service, as a commercial service, could be like an app for all life long. But for our clinical study, will be at least 1 year of usage. And so we are not expecting the daily use, but we expect the weekly use, okay? Weekly, and we will set up, so in order also to avoid to remind the user about the disease, but consider that a week could be the best usage time. No, not all the days, but maybe 2 days, 3 days a week. Okay, then user can use it with the frequency they want, for sure. But this is not for, I would say, intense monitoring. Okay. So here you see more or less the schema. For the activities type, we are thinking on mindfulness support, you know, to try to reduce anxiety and also improve quality of sleep. Some type of exercise that will be connected to rehabilitation exercise that the user is performing in specific clinic. This will be exercise that user can perform at home, not in the clinic. Some cognitive games, no, the brain teasing. We have an experience from a previous project that is called Hoop, that was for Parkinson. And here we have some already cognitive games that we can easily add in this project. And then for sure we would like to create some specific evidence-based content specific for the disease and specific to the needs of the user. So on this part, then I will show you how this will be done during the assessment in the hospital. All these services will be tailored, you know, by the clinician together with the patient. No? So this is more or less what we have as idea of functionalities, and then for sure we will try also to improve according also to your suggestion. And then for sure this part will be first developed as like I would say typical app with touchscreen functionalities, but with accessibility support. And then for sure we will add the voice command to control the app through the voice, and then we will add also this head armband sensor in order to control directly without the touch interaction, but just with the head neurological interaction. So this is more or less the app. Then I would like to give you just a quick overview of what is the web portal, what we are doing on that. Let me just, so here we have the home page. The home page, as I told you, should be able to try to stratify the patient according to the condition. Imagine a user that report specific symptoms, fatigue, for instance, multiple sclerosis. So we need to, a professional should put attention on that. So thanks to this type of risk assessment tool, we will be able to guide the health professional to go to revise the situation of a specific patient, and then to manage the patient through all the details of the data that we are getting to the app. We have an extensive procedure of enrollment that I would like to show you. This is the new patient procedure. This is like a procedure in which the health professional first make like an overall assessment about demographic data, disease history, the medication, the comorbidities, the clinical disability function, and then according to that, the system will be personalized. The health professional will decide together with the patient what will be the best services for the patient. Okay, and these are some screens that we have here. Let me check. Here we have the first screens for the new patient. Then if you follow the arrow, we have other types of forms. These are basically forms that we are discussing with the health professional. There are some specific assessment tools that will be used, IDSS, for instance, ALS, FRS scales, for instance, for functional assessment of MS and ALS. And then we will have also a final system, information which the user will be able to personalize the type of activities, the type of user interaction, and the type of games to be done, to be provided. Then there is also another interesting aspect that is the relapse management. According to the remote follow-up, will be possible to maybe schedule a new visit in a way that the health professional may acknowledge a relapse of the user, and this relapse also will be used by the AI models, to improve the accuracy and also to personalize, the progression evolution of the specific user. So here we have another example of possible form to report a visit, in which the professional report when the reason of this visit. There are some possible tests and questionnaire to be filled, and then in this there is the possibility to report and relapse. So this is more or less what we are doing at this stage, and then all of this, for sure, we will go through the management of all the information that we get from the wearable sensor, from the questionnaire in the app, and then we are still working on this part that are the prognostic tool, about criteria for stratification, how to take advantage of this early risk stratification, and how to take advantage of the prognostic tools, and what we try to discuss also before on this. So this is more or less the status, and for sure we have to continue working, and then most probably in the next autumn we are going to start presenting all this development to the end users, and to start also some usability around and discuss on how to improve. this is more or less the status of this. I don't know if you have some feedback, quick feedback on that. Also, if there are some questions for the public, I think that now is the time. Okay. So this is more or less what we have in mind, and we have to continue working. We will also integrate all the feedback that you provide during this session. So I think that since we have just 5 minutes, my proposal is just to start with this. Thank you very much first for your attendance. I will also want to thank European Connected Health Alliance for the support to arrange these meetings. And you know, if you have some last word or recommendation for this workshop, for the next activities of the BRAINTEASER, if you have some, now it's the time to do it. If not, my proposal is maybe to make the final photo of the panelist. So I invite you, all of you, to please switch on the camera, and I hope that Federica and Natalia will make like a screenshot of this. And really, I thank you all. We will try to keep you informed about the progress of this project. And if you, for sure, thank you very much for the attendance. And thank you to the audience. Thank you to the panelists for to provide all this type of feedback that I think that at this stage of the research are precious for us. And I hope that also we will keep connected to the social network, and maybe we will have another opportunities to meet again and discuss a bit more about how to improve the management of this two terrible disease as ALS and MS.
Thank you so much. I just want to say a quick and note of appreciation because as you know, I work in a community association, and for our community, for our patients and caregivers to be involved in these events, and to know that our people, investigators, clinicians, other associations involved with this type of activities means a lot to them, and they really appreciate. And I want to pass this message in the name of all the Portuguese community of LAS.
Thank you, Felipe. We are very proud to try to support this type of research, and I hope that also very soon we will keep again in contact to maybe discuss more and also understand other type of needs that can emerge. I mean, this is a research, is a journey for us, no? And we would like to go with the best companion, as you are, you know. So it's very, very nice, your feedback. Thank you.
I would also like to thank you very much. I think we will cooperate again in the future, and we certainly look forward for it. We have very much in common in our two projects, and it is also very useful from our side, this workshop. And thank you very much for this and your invitation and organization of the whole workshop.
Thank you, Panos. Yes, for sure, we will meet again. I mean, we are, for the public, this is a project that has been founded in the same European call this Alameda project. So, I mean, we are one of these selected one, the lucky one, and
Yes.
for sure we need to go all together and share the experience. This will be appreciated for our job, but also for the European Commission. It's important to have alliance, with
Yes.
other. There is not any competition really, because
No.
science is open. That's the approach in general. So we are very happy to have you here and also to further collaborate with your project.
Exactly. I couldn't agree more. Thank you.
Thank you, Manuel.
Manuel, if I may, just a final word from my side.
Yes,
The Great ECH Alliance, thanks to all of you. And please stay tuned for further initiatives. This is just the kickoff of our co-creation process and approach. And for sure, there will be other initiatives in the next future. We will keep all of you informed. Thanks a lot and have a nice day.
Thank you very much.
Thank you.
Now it's time to close the meeting. Thank you. Thank you very much for your time. Thank you for your ideas and feedback. Thank you.